At this time, I would like to introduce our speaker, Carol A. Clancy. Ms. Clancy is an adult nurse practitioner in occupational health with extensive training and experience in the diagnosis, treatment, and management of work-related injuries and illnesses and workers' compensation. She will be presenting on optimal COVID-19 safety precautions, which should be implemented to mitigate the risks of SARS-CoV-2 exposure to frontline workers. Currently, she is clinical manager in occupational health for Quadrant Health Strategies and provides healthcare services to corporate work sites across the United States. So at this time, I'd like to turn the floor over to Ms. Clancy.
Good evening, everyone. I have no conflicts of interest to disclose. And as far as my background, you'll notice I'll drop the R's when I'm tired and add them when I'm not. So I spent the majority of my time in the large teaching Boston hospitals. I've been an RN since '87 and NP since 1991. And in February of 2020, one of my friends talked me into going to biotech, the pharmaceutical. I did not know that there was going to be a pandemic, and I did not leave my peers, but it was very eye-opening and it was very interesting because I came from a big teaching hospital, was actually doing research. So it was a good transition to do that piece of it. But it was interesting to see how the difference, every year we had cases, Ebola, we were ready for Ebola, chikungunya, we had the H1N1, we got the vaccine out right away and we got into the seasonal flu. We thought that was going to be a pandemic. And it was just kind of very eye-opening for me that my colleagues didn't have the proper PPE in the hospitals. And I felt really bad about that. I'm sure everyone did, and not being prepared for it. And a lot of this being outsourced. We had to have Robert Kraft from the Patriots get his own plane and go to China and get us PPEs. And my colleagues had to reuse, and I'm sure you all have the same story. So it was amazing to see the difference between the hospital setting in that regard, not being prepared. I give them all kudos for being in the front lines and stuff, but not having the PPE was quite eye-opening. And to see the biotech and pharmaceutical companies have the PPE, and it was just interesting. Sorry, I go off on a tangent. So Dr. Kavanaugh mentioned that I should open with an example of a patient that was recently in the ICU with COVID. Now, this patient actually was a family member, 33-year-old, very healthy young man, no comorbidities, didn't have obesity, no diabetes, no cancer, no asthma. He never got around to getting his vaccine because he felt he was healthy, 33-year-old, and wasn't going to have a problem. So he ended up getting COVID-like symptoms and ended up testing positive. The next day he passed out and seized. It was his heart. So he was transferred by ambulance to a local hospital, and they did an echocardiogram on him and said that his EF, ejection fraction, was 25%, and that he had myocarditis. All those biomarkers, troponin, BNP, were all elevated. So they did a cath on him. He had clean coronaries. So they knew it was from COVID, and they had the myocarditis. And this place did not have ECMO. And they actually said to me that he isn't our sickest patient here and can't go in the unit. So the next day, thank God, he was able to get to Tufts where they did have ECMO, and his EF by that time was 10%. So the fellow cardiologist told my niece, be prepared for the worst. And the attending sat down and spoke with us and said that ECMO was not the last resort, that this actually is modality. He has an 85% chance. So with that, but to see a robust 33-year-old man with no color and no energy, it was awful. And they had him on remdesivir. He was on dextromethasone. He was did give him antibodies. He wasn't a candidate for the convalescent antibodies. They intubated him and put him on ECMO. And then his color came back and he looked pretty good. They extubated him and he woke up. And the first thing he said to his new wife of 2 months is, "Am I going to die?" We said, "We didn't know, but you're in good hands." And he was in good hands. So he had his follow-up appointment this Monday. His ejection fraction is 60%. They don't think he needs cardiac rehab. He's a miracle. And it was the ECMO that saved him in the wonderful care. And so people don't realize that if the facility can't provide that, he would have been dead. So that's something to think about too. And then just to see that when we're taxing our healthcare system with this, other people get sick and have other issues too, though. So the units were filled in that hospital, and in our big Boston hospitals, there was a waiting list. They wanted to know how bad he was because there was 35 people waiting, but he went to the top of the list, obviously. So things to think about. And I'm sure from different states, you go through the same thing. But that's the reality of the situation. We don't know why some people, what the attending said is that because he had such a robust immune system, it was a cytokine storm that attacked his heart. So being young and healthy and a robust immune system was one of the risk factors for him to have the myocarditis. So it was interesting, but he's doing well. So getting back to this, I'm sure everyone's familiar with the OSHA guidance on protecting workers and mitigating and preventing the spread of COVID in the workplace. So I won't go over that. It is a great resource for us, and they do update it. When we first went back, they were doing everything. They had the signs for 6 feet, and only certain amounts of the workforce could go back, only essential workers. And then when they got more data and things were coming better, they changed it and allowed more people to come back to work. And so as we see from things, as we go through the data and look at the numbers and respect the research, we see things are fluid, they change. And like Dr. Kavanaugh was just talking about the Delta variant, things are changing. We're seeing breakthrough cases, but we have to look at the data and go with the science on all these and to kind of go from there. Because I know there was a point in June where they actually said no one has to wear masks if you're vaccinated, and it kind of got rid of a lot of the mitigation that they were doing and then brought it all back because the research and the data were there. So what I'm going to do is I'm just going to give you a couple of examples of what I see as working in the biotech pharmaceutical companies. I'll use 2 of them, for example. And what they did is, in order to keep their staff safe, they did some engineering controls, administrative controls, and the PPE, of course. Their engineering, they increased the air exchange. They had plexiglass. When people work in, essential workers working in the lab, you can't close down. They have to continue to work. So they were able to do those engineering controls to keep them working by increasing the air exchange and having the plexiglass there. And as far as the administrative controls, they were able to get in policies in place where people could work from home. But if you were an essential worker, you were not able to work from home, as everyone knows. And they had to figure out how to keep them safe there, like in manufacturing. They didn't have the luxury of R&D of being able to work from home. And they had to come in and how could we keep them safe, and how could we not, bring COVID-19 in the workplace or bring it back to their family. So what they did is they did testing, a lot of testing, on-site testing and home testing. So employees would get tested once a week, and they also were given home test kits that they could test at home. And this was a molecular nucleic acid amplification test that went to a lab that's considered the gold standard, that they could actually put in the envelope and send to FedEx and get the results in 2 to 3 days for that. And the test on site was similar to that was sent out, and they can get the results. When the numbers were getting better and allowed more employees to come back on site, they allowed some meetings to happen, but the person had to test with a molecular PCR test or LAMP test, had to be negative 72 hours before coming back on site, as well as they had to have an antigen test 6 hours before the meeting, the daily meeting. So I saw the difference where talking to my colleagues working in the hospital settings, they would say, we are really nervous about bringing it home to our families who want to be tested, and they wouldn't test us if we weren't symptomatic. So whereas, in the biotech companies, if you were symptomatic, you weren't coming in, or you think you had exposure where you weren't coming in. I'm sure they did at the hospitals too, but they allowed people to be tested when they wanted to. That was a difference that I noticed too between the two. And they did a great job of case management. And that was our piece. People will call and say, well, I got a lot in the beginning in March of 2020. People would call and say, I have watery eyes and scratchy throat, and I'm sneezing. Do I have COVID? And I said, well, have you ever had these symptoms before? And some of them were having allergies, and they took their allergy medication, they were fine. But other people, they were able to get tested, so for them to get tested, trying to find a place, different states had a lot different places to get tested, free testing, and to make it accessible to everyone. So that was a good thing, as well as different scenarios. So if a family member was exposed to someone, they want to know, did they have to be quarantined? Well, not unless the family member showed symptoms. So it was more the case management, and they've changed. And what we used was the CDC guidelines, but different companies could be more conservative than the CDC, and they were, for testing and having people back, but they couldn't be less than the CDC. So we help with guidance with that. And as far as HR played a big role, because not everyone could afford to stay home if they were told they had a quarantine. And all of a sudden, I had cases where one family member would get it, and then they had to wait the 10 days, and then you had to go the 10 days from there. And then another family, they didn't all get it at the same time. And so they weren't allowed to go back. They did have a fund in the beginning for people for COVID time, and majority did not abuse it. They actually have another, like one of the companies, if you're out more than 7 days, you can go right into short-term disability. So that's what they do now. But it is the burden for people. They're afraid to tell you if they have a cough or a sneezing. There's other things going around, regular cold and viruses there as well. They're afraid, but we do obviously have them tested, and they have that access to being tested. The other big thing is vaccination to encourage. And I know that the federal government put in, now it's kind of on hold for now, but you have 100 more employees to be vaccinated. And if they can't be vaccinated, then they have to have a good reason. So they would have to, through our medical director, to see if they had true allergies or anaphylactic reaction to any component of the vaccines, saying that they couldn't, and what we do to mitigate them and keep them safe at work. And also, if there was a religious exemption, that would have to go through HR, and that would have to be decided by HR if it was legitimate. And then they would have apps. One of the companies still has an app. You have to go in and you had to upload that you were vaccinated and that you have no COVID symptoms. And if you have COVID symptoms, you're not allowed in the building. And then you have to talk to someone in occupational health before you're allowed to go back. I know they started out strong in the hospitals. I don't think they do it as much. I think it's more on the managers as far as that going in, although they do visitors. When you go in, they do ask you, have you been exposed and do you have symptoms? So they do that, but I'm not sure as much with the employees is being done right now, but each hospital is a little different. And then just creative minds, being open-minded and, listening to the science and trying to keep everyone healthy and safe and working, but being practical at the same time. Does anyone have any questions as far as the mitigation is going or the case management piece of it?
Hi, Carol. I was wondering if you could explain to people the difference in treatment and why the ECMO benefited your nephew so much as opposed to being in a unit without that capability.
So it really has changed, and it has evolved as they learn more about science. They're not ready to intubate people right away. They wanted to extubate him as soon as possible. He never really had the respiratory issues. His was more, it attacked the heart, the myocarditis that he had. So they felt like with the ECMO, it bypassed the heart. So it's extracorporeal membrane oxygenation. It was able to oxygenate his blood, and he didn't have to be intubated. So you see, it's like a 2-inch tube that's going back, and the machine isn't that big, kind of like the bypass machine. And it was able to oxygenate his blood, and he did well. And then between the combination of the remdesivir and the steroid, giving him time for his own heart to heal and kick in, the attending was pretty confident in this. But his case was actually, it wasn't just Tufts. They conferred with the other Boston hospitals on what was the best treatment for him. And that's what they came up with. Again, in the beginning, when it happened, they did have people on respirators, and it was a different treatment. I mean, hydroxychloroquine was one of the treatments, and they learned it really doesn't work. So I think as more time goes on, more data is out there, they're learning more about how to treat it in certain parts of the body that it's affecting. Now, his didn't affect his respiratory system like other people. So his O2 sats never really crashed. I mean, when his heart wasn't working as well, it was going down to low 90s. And if he exerted himself, it would go into the 80s. But he really didn't have the respiratory component of COVID-19.
Okay, well, thank you very much. It was a very enlightening talk. I think that some of the differences that I heard you articulate is that testing was widely available at your company. You could have it 3 times a week if you wanted, as opposed to healthcare industry. You had abundant PPE at the company. And it also sounds like that you've had paid leave off and even going on short-term disability without any big hassles. You would call in if you were sick and take time off rather than worry about having to come into work sick for fear of being laid off or sent home without any benefits. And that certainly is, I think, different than a lot of frontline workers were experiencing throughout their time treating and putting their lives at risk, treating patients with COVID-19.